I'm privileged to have had my great and good friend, Professor William Rea, here lecturing in our new building. He's been the inaugural speaker, and we've been able to capture this for everyone to enjoy for the future. Thank you, Bill.
I'm Dr. Bill Rea from the Environmental Health Center in Dallas, Texas, USA, and I've asked to talk on the history of chemical sensitivity. Now, what is chemical sensitivity? It's the adverse reaction to the ambient dose of toxic and non-toxic chemicals contained in air, food, and water. Now, the first in the literature that we could find was our friend Hippocrates, who was our teacher, of course, back several thousand years ago. And he observed that some people could eat cheese and do well, while others, it would make them sick. And our principles in environmental medicine are based on those observations. The second thing he also noticed was if a person fasted for 3 days and on the fourth day started to eat, and if they took the wrong food, they would become quite ill. So with these things in idea, the Gray's Anatomy and Guyton's Physiology really fits in very nicely with this problem. We also found out that the biochemistry, Dr. Al Corwin at the Johns Hopkins University and Dr. Linus Pauling, the Nobel Prize winner, and Jeff Bland found the basic principles of detoxification and nutrient support. Then Hans Selye showed the specific adaptation syndrome, whereas a person would get used to a substance if they kept repeating it and taking it into their body, either food, air, or drink. Francis Hare from Australia also described the food factor in disease. Albert Rowe in 1931 also observed these same things. Herb Rinkel also observed the masking phenomena or adaptation phenomena when it came to foods. The French Hansel, an ENT surgeon, found that optimal dosage concept in 1941, which is our treatment and neutralization by injection, goes on. And then in 1950, Theron Randolph from Chicago described the specific adaptation to the triggering of chemicals in foods. Randolph published his first book, Human Ecology and Susceptibility to the Chemical Environment, which was the first description, good one, of the chemical problem. Jim Wilby of Kansas City also showed that if you used adaptation serially, you could titrate patients' treatment. Ed Brinkley in Colorado also described chemicals in 1964 and found that they could bother people. And John McLennan in Hamilton, Ontario in 1974 described this phenomenon also. Lawrence Dickey from Fort Collins, Colorado, was the first to develop the first environmental control unit based on Randolph's ideas of adaptation, unmasking, and decrease in total environmental load. Carlton Lee was a physician who developed the intradermal neutralization in 1967, and then Joe Miller in Mobile, Alabama, found this. He refined it very well, where you could test patients and treat them. Now, the next thing is that we wanted to find the principles of environmental medicine, and these came about in several ways. First, of course, was the total body load, the masking, the bipolarity of response, the multi-biochemical individuality, and the switch phenomena. And we were going to take one of these simply and look at them, and this is first the total environmental load. The total environmental load is the consequence of patients' food, air, and water. And each one of these contain multi-factors that will make people ill and or make them well. And the first principle is the total body load of the barrel. And you can see in this total environmental load how there are so many things that we get in our air, food, and water. And of course, this is multifactorial and only a list of some of the most common ones. For example, in the air, maybe pesticides, maybe car exhaust, jet fuel, so on. And in the indoor air, of course, is many things that can cause problems like carpets and paints and so on like that. And of course, with the other phenomena of food, you will see a masking phenomena that can occur. Now, if we go to separate these principles in a more orderly fashion, you can see that if you look at the body as a barrel, the barrel is the sum total of pollutants that the person takes in air, food, and water at any time. The second thing is the adaptation phenomena or masking phenomena in which a person gets used to a substance. So if he gets used to a beverage, he may get addicted to it. If he gets used to smoke, he'll get addicted to that. If he gets addicted to other substances, this patient will get used to these phenomena, being incorporated into his body and causing him to be ill in the long run, causing disease process. Finally, the third one is that there's no two people that look totally alike or act totally alike in this world. They're all different. And therefore, they have a biochemical individuality in which they would respond differently. So subject A would respond one way, subject B might have another response, subject C might have no response whatsoever. So these type phenomena goes on. The other thing is that a person can get used to a substance for a long time and do very well and have no illness, and then suddenly switch to another reaction. For example, a person may get sprayed with a herbicide next to a field, and all of a sudden their switch changes, and from them becoming normal to them becoming asthmatic or having blood vessel dysfunction or having brain dysfunction, which is a big one. And of course, the other thing is people can have biochemical individual response. They will have stimulatory phases and inhibitory phases. Therefore, they may at times get stimulated by a substance, and then at other times they'll get real calmed down by the substance, but in the long run, this will damage them and accumulate their total body load. And finally, what one sees is there's a spreading phenomena. And a person will say, well, I can't eat onions, and that's all there is to it. And they have no trouble with any food. But as time goes on and their barrel gets full, they may have a phenomenon where then they can't eat beef, or they can't eat chicken, or they can't eat peas, and so on down the line as the spreading phenomena occurs. And of course, the last two principles that one sees are those of nerve damage. And the law of nerve injury says that when a nerve is healed, and we know this as surgeons, that even though the nerve is healed, the pain's gone, people can move their muscles or they can move their organs quite well, that if they get hit again, they may not, that memory of that in that nerve may come back and they will be vulnerable. The other thing is that a lot of these things that we find out have subtle head injuries. For example, as a kid they got knocked out or they just got whacked in the head and got stunned for a little bit. They may have played football and basketball or something that damaged them, and yet they recovered and seemed to be normal. But then their second hit, which might be a pesticide or herbicide or some other bacteria or virus, they might then get short-term memory loss. And one thing we see in the people with the chemical and electric sensitivity is the short-term memory loss, where they just suddenly can't remember certain events or certain concepts when it's told to them. But in the long run, as they study it, they can remember it and function fairly well in society. And so too many of these hits, if you violate some of the principles that we just talked about, you may have the chemical sensitivity or electrical sensitivity occur. Now, I thought I would show a few examples of these, and the technology that we helped bring to fruition was important because up until about 25 years ago, very few of the public and most of the medical profession didn't believe in chemical sensitivity. However, now with the technology being brought to it, the public has now got the concept, and almost any person coming into or you talk to realize you can have chemical sensitivity, and they're starting to realize you can have chemical sensitivity. Now, some of the materials we did, like oxygenation and rotary diet and nutrition, came from cardiovascular surgery, whereas I happen to be a cardiovascular surgery, and we use these in heart surgery and blood vessel surgery for years. And this was done at the University of Texas in Southwestern Medical School, Veterans Hospital, Parkland's Hospital, and so on down the line. Now, as you can see, these are pictures of rooms that are environmentally designed so that they're less polluted and that the barrel can be drained for the patient. And this is hard ceramic floors with non-toxic grout, beds that now we're finding out may be a problem because of the electric phenomena, but was one in which you could have the chemical phenomena curtailed. Organic cotton materials and glass, the use of glass. And this just shows another area in our clinic where we use the organic cotton, hardwood, not pine or cedar because of the odor of those, and porcelain fired, which is basically glass fired at 2,000 degrees on the steel. We found out that porcelain fired at, or sand fired at 1,200 degrees was not satisfactory for a lot of our patients. This slide shows a lady with all cotton and silk on her, and that's what we like in the unit. We usually use all cotton or silk if we can, or linen for the people to reduce their total load and drain their barrel. And this just happens to be a room where we test patients. And again, as you can see, the air has been measured in those rooms, and they're 5 times less polluted than the average room. And so that makes a big difference in decreasing the load and testing properly. Now, some of the history of this is that Professor Fennevis, Department of Physics, University of Texas, and Robert Edgar, who was his student, measured buildings. And what they did is measure the air in the buildings and measured particulate matter, and also did a lot of air analysis with Matrix Lab. And what they found was that there was a massive decrease, at least 5 times, in the particulate matter, and also in the air analyses for organic chemicals, pesticides, and herbicides. And they found that about 1,000 analyses that this was formaldehyde-free and benzene and phenol less polluted, so that there was all kind of volatile organic hydrocarbons that were found not to be there, that when compared to a regular building was there. And so this was highly significant in decreasing the load and showing the masking phenomena and how you can remove the masking with good air analysis and good air that people can do. Now, the other thing that was found was that we put a lot of patients in there with cardiovascular disease, thrombophlebitis, and different vasculitis phenomena, and also heart irregularities, and found out that they could be cleared and without medication. And that was the neat thing about it. And then they could be reproduced by challenge. And there was a ear, nose, and throat surgeon in Australia who took nasal biopsies and found in 100 patients the foods and molds in the noses and sinuses of these people. Then the other thing that was brought to line was Professor John Lasseter from the University of New Orleans, who did a gas chromatography and blood analysis for our patients and found them loaded with different chemicals like benzene, toluene, styrene, and herbicides and pesticides. And he did this in about 20,000 patients, so it's on a good stabilized zone that you can measure the toxics in patients, some toxic. Now you have to remember there are 80,000 toxic chemicals in the environment, and there are something like 500,000 molds, and of course multiple electric waves. So we still have a problem of measuring the total environmental load, but it's much better than it would than it used to be, so that the toxics can be found in many patients. We're still finding organochlorines because of their long half-lives. So sometimes, for example, DDT and DDE last for a half-life of 50 years, so they're going to be around over 150 years. And that's staggering when you think of it. And we still find patients with this in their blood because they're living in houses that had these substances used right after the war. Because I don't know any of you remember seeing the pictures of them spraying right after World War II. And people were apparently got zapped and didn't even know it, or it took a long time for their problems to occur. And of course, Metamatrix has found the organophosphate pesticides. Now, the other thing that's always been occurred on a new disease or a new substances or entity that a person, the profession doesn't really care about or want to know about is it's psychological. So Professor Butler and Nancy Diedrichson from the University of North Texas worked out technology from a psychological point of view of where pretty much you could tell whether a person had real organic brain damage or they had psychological problems. And they have done now about 3,000 profiles that has correlated this with brain scans and shown that the chemical problem and even now the electromagnetic can be shown by triple camera 3D. It has to be 3D brain scans. And this is where Ted Simon and David Hickey came in, where they worked with Dallas Radiological Associates, developed the triple camera brain scan for the chemical sensitivity problem. And they have done now over almost 700 scans showing the chemical sensitivity program and scans. And I wanted to show you this. This is triple camera SPECT scans. And here's a normal. And the nice thing about it, you can see the 3D, and you can see how smooth it is and how yellow it is, and there's no indentations in it. And if you look over at the lower one, you see areas that are very well defined. Now, if you want to look at a scan on the next slide of which is abnormal. You can see it's a fuzzy outline. You can see actual holes in the head, in the brain that go by. And then the temporal lobes, which were very sharply outlined, are now fuzzy and you can't really see them. And that's apparently where the short-term memory loss lies in the chemical problem. There is a study that just came out recently that showed that the chemicals can go right up the nose and into the limbic system, which is apparently the normal pathway. But in the chemically sensitive, it goes up into the frontal lobe and then goes into the limbic system, and so can count for the memory loss both ways. Now, the other thing that's happened is that pupillography occurs and Professor Ishikawa, who is the professor of eye surgeon at Kitasato University in Japan, developed a machine that could show changes in the autonomic nervous system of the brain. And he did about 600 patients in our center over a period of years that showed changes in the autonomic nervous system. The other changes in the autonomic nervous system can be shown by heart rate variability. And this we've done for years, and we have over 1,500 patients now that have abnormal autonomic nervous system, which is another classic of people with chemical sensitivity. And finally, Dr. Overberg from our center has shown that oral nutrition and IV nutrition is quite good, and many companies around the world now can you show you nutritional deficits, and then these can be corrected both clinically and simultaneously. And so the next thing that happens is that on the next slide you'll see an immune deregulation. At one time there was no mechanisms that could be found for chemical sensitivity. However, with the development of T cells, B cells, complements, and gammaglobulins and their subsets, you can find abnormalities in these. And the interesting thing is, for example, IgG subsets that are 1, 2, 3, and 4, there's about 30% of the chemically sensitive people have gammaglobulin abnormalities, which can be corrected by 1, decreasing the total body load, and then 2, by even supplementing with gammaglobulin shots for 1 to 2 to 3 months. And we have done that now in probably several hundred patients. And of course, the T cell deficiency has been measured over and over again, not only by us, but other people. And these have all been reported in the literature, and showing that T3, T4, T8 can be abnormal. And Bertie Griffith, Dr. Griffiths at our facility developed a idea that maybe we could take the patient's own blood, grow it in culture, and let the bad cells die and the good cells divide and get stronger. And after about 30 generations, you could do an extract of this substance, and it would promote the low T cells and therefore promote immunity. And we've now used this in about 1,500 patients. And the neat thing is it's really their own cells, so very few of them react, and they're actually just stronger cells, and the patients get energy and can fend off substances more. So the success rate on this has been about 90%. Now, the next thing that happened in the history, I think, is that the development of mycotoxins, which are another group of toxins that people have not talked about much. And Dennis Hooper developed the fact that he could get mycotoxins from patients' urine and from their hair. And these mycotoxins have been found now to correlate with the person's exposure to mold, and particularly in their home, but any place. where they get a lot of repetition of this. And that has been a great boon to the environmental sensitivity. And then finally, Jean Monroe and Cyril Smith at the Breakspear Hospital in England showed in '82 that there was electrical sensitivity involved in this. And they have used this, and we have used their principles over the years in their different apparatuses for producing the challenge. Now, the challenge tests are very important in chemical and electrical sensitivity, and of course, the most common one is oral, eating something, drinking something, things like that. If you avoid a substance for 4 days, like Hippocrates told us several thousand years ago, and then eat the substances or drink the substances, you can have an acute reaction. And your body will tell you that you can have problems. Now, we expanded this, first the intradermal challenges were done by Willoughby and by Carlton Lee and Joe Miller, showing that you could actually not only provoke the substance by giving an intradermal challenge, but you could also clear the substance by giving the proper neutralizing dose. And then finally, inhaled challenges where you can take ambient doses, very small doses, like of chlorine or pesticides, formaldehyde and phenol, substances that authorities said were non-problems, and found that the chemical sensitivity person would reproduce all their symptoms in this. Now, also the nutrition field got pushed ahead by Jeff Bland and Linus Pauling and Martin Paul, who showed in areas that nutrition was damaged. And of course, we've done over 10,000 patients, working them up for nutrition, and been able to clear their symptoms somewhat. Now, and with the electromagnetics, I can't have time to have the room, but we have a screened room where we actually challenge people with ambient doses of electromagnetics. And of course, these are like from Wi-Fi meters or different types of transformers or substances, and been able to show that these people can have their symptoms reproduced. Shielding is usually by copper, aluminum, sometimes silver, and there are gowns made out of these now, and blankets, and all different kind of protective devices, but very difficult. Now, secondary to this, we've had environmental units all around the world. Dr. Monroe in England was a great example of this, and we've had several in the United States, and Dr. Roy Fox in Canada has developed a unit, and Al Robbins in Florida, and then Klaus Runo developed one in Emstal, Germany, which was closed and now I understand is open again, and Dr. Pilar Munoz in Spain, and Colin Little in Melbourne, Australia, and Hong Yu Zhang in Peking, China, and the Ishikawas in Tokyo. There are some societies got out for this now, and the American Academy of Environmental Medicine Society for Environment and Nutrition, and the Pan American Allergy Society are some in the United States, and then there's, of course, the Australian Ear, Nose, and Throat Society, and some physicians doing this type of substance are occurred all over the world. This is a challenge of a small room, environmentally controlled, with a glass booth in it, where you can put ambient doses of substances in there, or blanks, and provoke the patient. This just shows non-toxic antigens, as we have in Dallas, no preservatives, and the same with Dr. Monroe. And of course, this has been a big boon, because when you inject salt water, you know it's salt water. If you inject a food, why, say beef, you know it's just beef and not a preservative. And if you did inject other substances, chemicals, you know that's that substance. Now, the other thing we show is the T and B cells, the complements, and the gammaglobulins, and EMF frequency by Dr. Smith, who has perfected this, and he and Dr. Monroe have used this quite well clinically. This is one of the Airstream commercial trailers made out of aluminum, but stripped down on the inside. And we powdered our unit so that we have in Dallas, along with the Marriott Motel, and developed some inside. So if you look at the next slide, okay, you can see, again, much the model similar to what we had in our environmental unit, where you got ceramic floors and you got hardwood and ceramic walls. Glass tables have been made, and of course the different bedding with organic cotton on it. Non-toxic cleaners being used. Green soap is one of the big things. There are many homes that have been constructed now throughout the world. You can see that there are all kind of technology been brought to these homes, and also natural dyes for like the couches and the carpets, hard chairs of different types, a use of glass and ceramic and non-toxic metals. Of course, we don't recommend fireplaces in the right upper hand corner, except for heaters, electric heaters, because people have trouble with these. Then there's the hardwood chairs that have been, and silk. Some people use a lot of silk in their furniture and upwear. And of course, there's aluminum wallpaper now that have been done. This one up in the right upper hand corner there shows aluminum wallpaper that's been printed and very nice. And the abundant use of glass again and ceramic. Now the history of chemical sensitivities, intradermal wheels and neutralizations are quite used in the clinic, and these were the three people that developed that. The oral nutrition and was developed by Pauling and Bland, and then the IV nutrition we had always used in our surgical practice. And Stan Dedrick out from the East Coast of America and myself developed total parenteral nutrition, where you can actually thread a catheter up into the heart and use this for total nutrition. And so the patients who have real bad food sensitivity and can't eat any foods and have lost weight, you can give them total nutrition. And we've done this anywhere from 1 to 3 or 4 months on kept a patient alive and gaining weight and correcting their GI tract while it was at a rest. And this does make a big difference. Now, the other thing we might do besides the avoidance, the intradermal neutralization, and the nutrition is oxygen therapy. And what's been found is that the Professor von Arden in Germany, East Germany, found that you can cross the lungs with oxygen very well in many people. And Western medicine, up to that point, always felt the big problem with the lack of oxygen was just lung problems. You had linings in the lungs that wouldn't exchange oxygen. But von Arden found that, and we have seen in our cardiovascular patients, that you can get enough oxygen to them, but the muscles and the cells in the brain and the nerves and so on have to take the oxygen out. And if there's no exchange or little exchange of oxygen, then of course you can help patients markedly with that. So we use liberally the fourth element is oxygen therapy in many patients, where they'll take oxygen for anywhere from 18 days to 36 days at anywhere from 4 to 8 liters for 2 hours. and that will correct the exchange problem in the tissues, and a lot of times clear up their brains, and a lot of times clear up their muscles where they get energy on this. Next slide, we've already talked about Bertie Griffiths and his oxygen, his T lymphocyte therapy. Now, the next slide is oxygen therapy. And if you'll take on the next slide, we can see what we've done. We like to use the old-fashioned big green tanks yet because of the oxygen concentrators are full of plastic, and a lot of patients react to them. Some people can use them, but you have to use the older tanks with better. We use the glass bottles instead of plastic bottles, which he used, and then we use cellophane, which is a non-plastic, as the reservoir, and then instead of plastic masks, we would use either aluminum masks or ceramic masks, as shown in this slide here. And here's a patient getting that therapy. The other thing that's used, obviously, is energy manipulation, and these are this brings in sort of Oriental medicine and the other people who have, I don't know, I guess I would call it as a surgeon clairvoyance. They can see things we can't see, and they seem to help these people with that. The other thing about the history of chemical sensitivity is that what we've found, and I think Dr. Monroe has found that also, that 80% of the people with electrical sensitivity have chemical sensitivity. Now, Becker and Marino, who Becker's an orthopedic surgeon, found that you can heal bones faster by giving them certain frequencies of electricity. And we've also found you can heal wounds faster by giving them certain electrical frequencies. And that's individual, and you can do that. So in summary then, the diagnosis and treatment now of chemical sensitivity is very well done, both clinically and scientifically, and that when you look at the principles of chemical sensitivity and then at the basic therapy of avoidance to keep the total load down, injection therapy to neutralize the hypersensitivity response, the nutrition, replacing of the nutrition, replacing of the oxygen, which if the way you want to look at it is nutrition, then and also these other manipulations, people can do well and usually clear of their sensitivity, although some of them may be very vulnerable. Thank you very much.